السلام. طيب. Okay. Good evening. Today we'll talk about ischemic heart disease. شايفين سلايدات؟ شايف سلايد؟ شايفينها؟
دكتور.
Okay. طيب بس. Okay, we start by this scenario. 60-year-old male patient, smoker, diabetic, presented complaining of chest pain of 6 month duration. The pain is retrosternal, heavy in nature, precipitated by exertion, relieved by rest. And each attack of pain lasts about 5 minutes. This is typical presentation of what? Stable angina. This is typical presentation of stable angina, which is one common presentation of ischemic heart disease. Okay. Cardiovascular disease is the leading cause of death worldwide, as you see here, more than other diseases, even more than cancers, injuries, pulmonary diseases. Okay. Some anatomy about heart. The heart is about the size of your fist. This is the fist. Okay. And the weight of the heart is just about 300 to 450 grams. You can imagine this small muscle, okay, that weight about 300 grams and the size of your fist, okay, keep continuing pumping, okay, since utero life till the patient or the person die, okay. So the average beat for this heart is about 70 beats per minute. It depends on the situation of the person. Is he comfortable exercising, anxious, stressed, but can increase by exercise and decrease by rest. Okay. And each time the heart beat 70 cc of blood for every beat, 70 cc of blood. So you can imagine how the size or the volume of the blood that ejected from the heart per day. To keep this muscle pumping, the muscle need to have a good blood supply. And the first arterial branch that comes from the aorta is going to go to the heart, supply the heart. And the heart is mainly supplied by two coronary systems. One on the left, start by left main, that divide to left anterior descending artery and circumflex, and one on the right, okay. These keep supplying the blood to keep the heart pumping, okay. And during basal cardiac circulation, about 70 to 80 ml per minute per 100 gram. This is the basal flow of the blood through the coronary arteries. And this can increase up to 8 times during exercise. To meet this increasement in the blood flow, you need to have a good patent coronary arteries. If the artery is diseased or narrowed by atherosclerosis, for example, okay, this cannot be met. So the amount that need to be increased not going to increase due to the narrowing of the coronary artery, and the patient will suffer ischemic symptoms. One characteristic thing about the heart muscle is that characterized by high oxygen extraction. And this extraction is fixed up to 75%. Back skeletal muscles, where the oxygen extraction, okay, variable depend on the state of the exercise. During the rest, the oxygen extraction decreased. During exercise, skeletal muscle, the oxygen extraction increased. But in the heart muscle, the oxygen extraction is high, and fixed, okay, it will not increase by exercise. Other thing about the coronary circulation, that 80% of the coronary flow occurs in the systolic phase of cardiac cycle. Other organs, the blood flow to other organs, for example, brain, kidneys, liver, it happens mainly during systolic phase of the cardiac cycle. So there is some differences, physiological aspect of coronary circulation. Ischemic heart disease, we classify it to two big groups: chronic coronary syndrome and acute coronary syndrome. Okay? So we have chronic coronary syndrome and acute coronary syndrome. The ischemic heart disease results when there is imbalance between the oxygen myocardial demand and the oxygen myocardial supply. Okay? What factor that affect the oxygen myocardial demand? Number one, heart rate. If the heart rate increased, there's increase in the oxygen demand for the myocardium. If the heart rate decreased, there's decrease in the oxygen demand. For that reason, patient with ischemic heart disease should avoid tachycardia. Tachycardia is not good for patient with ischemic heart disease because tachycardia increase oxygen demand. And for that reason, we give a drug to decrease the heart rate, like beta blockers. Beta blockers is one cornerstone in the treatment of ischemic heart disease. Well, through one mechanism, through decreased heart rate. Other factor that affect oxygen demand to the myocardium is contractility, muscle contractility. The more the contractility, the more again we treat it by beta blocker, okay, to decrease the contractility. Third factor that affects oxygen demand is myocardial or left ventricular wall tension. The more in the wall tension, the more oxygen demand. The fourth factor is muscle mass of the myocardium. Increasing the muscle mass, like left ventricular hypertrophy, will increase oxygen demand. Supply is affected by coronary flow, which depends on the patency of the coronary arteries. If the artery is patent or not patent, disease or not disease, this will affect the blood supply to the myocardium. Second factor that affects myocardial oxygen supply is hemoglobin level. We know that oxygen is carried in circulation through over the hemoglobin. With the hemoglobin decrease, as in anemia, the myocardial oxygen supply is decreased. So we should avoid any anemia in patient with ischemic heart disease. Okay, arterial wall oxygen saturation, systemic hypoxemia will decrease the oxygen myocardial supply. So normally, when the demand increase, there should be increase in the blood supply, blood flow. Okay, if there is imbalance between demand and supply, the patient or the heart will suffer ischemic heart symptoms. So ischemic heart disease results from imbalance between oxygen myocardial demand and oxygen myocardial supply. Again, normally, when there is increase in the demand for myocardial supply, demand to myocardium oxygen, they should be met by increase in the supply, coronary blood flow. If there is imbalance between these two, the patient will suffer ischemic heart disease symptoms. What are the causes of coronary artery disease? The commonest cause of coronary artery disease is atherosclerosis, which account up to 95% of all cases of coronary artery disease. About 5% of coronary artery disease caused by non-atherosclerotic causes, like vasculitis, systemic lupus, rheumatoid, Takayasu, or coronary embolization, or coronary mural thickening, like amyloidosis or radiation, or coronary luminal narrowing, like spasm or dissection, or congenital anomalies. Instead of originating from the aorta, sometimes this coronary originates from pulmonary trunk. In this case, the oxygen supply decreased because the saturation of the blood coming from the pulmonary arteries is much lower than oxygen saturation that comes from aorta. This is rare, 5% caused by non-atherosclerosis. But the main cause of coronary artery disease is atherosclerosis. Atherosclerosis is a diffuse disease that affects any artery in our body and start early childhood and result from interaction between genetics and environmental factors. We have many risk factors that increase the incidence of atherosclerosis, like modifiable risk factors like smoking, hypertension, diabetes, okay, truncal obesity, hyperlipidemias, okay, sedentary life, stressful life, all this increase the risk for atherosclerosis. So we classify risk factors for atherosclerosis to modifiable or reversible or treatable risk factor, and non-modifiable, not reversible risk factor. Modifiable risk factor are number one, hypertension, systolic or diastolic hypertension, will increase the incidence of atherosclerosis. Cigarette smoking, active or passive smoking, increase the incidence of atherosclerosis. Hyperlipidemia in the form of raised LDL or low HDL or raised triglyceride, and diabetes mellitus. This is the major four modifiable risk factors. Again, what are the modifiable risk factors for atherosclerosis? Number one, hypertension, smoking, hyperlipidemia, and diabetes. Risk factor, dietary factors, high fatty diet, lack of exercise, obesity, especially truncal obesity, homocysteinias, lipoprotein A, hyperuricemia, all these increase the incidence for atherosclerosis and can be corrected or treated or reversed. On the other hand, we have non-modifiable risk factors like family history. Patient and family history that one of his member, close first degree relative, for example, brother, father, or mother, sister has ischemic heart disease in early age. Okay, we consider the family history positive if it affects on the male side less than 55, on the female side less than 65. يعني إذا عنده أبوه أو أخوه عنده ischemic heart disease عمره أقل من 55 أو أخته أو أمه أقل من 65. أو the age itself is a risk factor. We consider the age a risk factor in the male more than 45, in the female more than 55. Female عادة 10 years later than males to be affected by atherosclerosis due to many factors. One important factor is estrogen protection. Okay. شكرا. طيب اذا عندنا modifiable risk factor، فعندنا non modifiable risk factors. Okay. The atherosclerosis start early childhood. Okay. زي ما حكينا interaction between genetics and environmental factors. The progression varied from one person to other persons. Okay. And they start by endothelial dysfunction, then that increase permeability of endothelium to the LDL, especially oxidized LDL. This will accumulate in the subintimal layer, okay, with migration of monocyte macrophage. This will engulf the LDL and then form foam cell, and this foam cell collected together to form atherosclerotic plaque. And this plaque progress with time, okay, till it lead to stenosis of the coronary artery or sometime rupture of the plaque that lead to acute coronary syndrome or as myocardial infarction. When the patient present to us, it's actually too late. What we see when he present to us is the tip of the iceberg. Before the patient present with symptom, many processes take time for long times. Okay, so we don't want patient to present late with symptom. Actually, we should deal before he start to have symptom in the form of primary prevention. So when he present to symptom, it's too late actually. Okay, معناها this patient has atherosclerosis for a long time that progress that lead to significant stenosis or acute rupture that lead to acute coronary syndrome. How patients with ischemic heart disease may present to us. There's a wide spectrum of presentation of ischemic heart disease patient. He may present with chest pain in the form of stable angina or variant angina or acute coronary syndrome as myocardial infarction or unstable angina. And between these two, he may present with symptom of heart failure as a complication of ischemic heart disease. He may present with arrhythmia, ventricular atrial arrhythmia, or sometimes sudden cardiac death. Could be the first presentation of ischemic heart disease. So the presentation is so wide spectrum, ranging from asymptomatic to sudden cardiac death. Between these two spectrums, the patient may present with stable angina, chest pain on exertion, or variant angina, or acute coronary syndrome, myocardial infarction, or unstable angina, or complication like heart failure, arrhythmia, or sudden cardiac death. Stable angina is one common form of angina. It's one common presentation of ischemic heart disease. It results from imbalance between oxygen myocardial demand and supply, and characterized by chest pain that comes on exertion and relieved by rest. The pain usually retrosternal, central chest pain, or it could be other atypical site, like left shoulder, left arm, left forearm, او neck, sometimes jaw pain او toothache pain. بقول لك يا دكتور بس امشي طاحونتي بتوجعني او سني بوجعني او حنكي بوجعني او ركبتي بتوجعني. ما في chest pain. Okay, and this pain relieved by rest. This is angina actually. Okay, and the pain of chest pain usually is squeezing or compressive or heaviness or burning. Sometimes patient cannot describe it, and he will say that the patient, I feel uncomfortable over my chest, retrosternal chest side. The duration of the pain usually lasts about up to 10 minutes, and usually precipitated by anything that increase the heart rate. Okay, like exercise, emotional upset, heavy meals. Okay, and relief by rest or sublingual nitrate could be associated with dyspnea, short of breath, or sweating or nausea. Okay, physical examination is usually normal, but you should look for signs of risk factor, hypertension, diabetes, hyperlipidemia, and should look for signs of peripheral vascular disease or atherosclerosis in other territories. It should feel the pulse in the lower limb. Okay, so ask symptom of intermittent claudication and should auscultate over the carotid brewery to look for presence of atherosclerosis over the carotid arteries. This is the site of typical site, retrosternal, and the pain may radiate left shoulder, left arm, forearm, ulnar aspect of the hand, or atypical site. Look for this scenario. And this patient is diabetic, okay, presented with toothache of 3 months duration. This pain, toothache, precipitated by exertion and relieved by rest and lasts about 5 minutes. Okay, this is typical again of angina in a typical site. Okay, a few months ago, we have a patient typical like this. He presented to us with toothache and he was seen many dentists. Okay, and manipulation was done, treatment was done for him, but no improvement till he came to us. Okay, he described pain that common exertion over his tooth and relieved by rest. This is typical angina. Okay, then we did for him angio, cath يعني قسطرة. Okay, and we found that he has tight stenosis of one of the coronary artery in the LAD. And we open it and we put a stent and everything is resolved after that. Okay, this other typical site of angina زي ما حكينا could be in the jaw, in the teeth, in the neck, trans shoulder, epigastrium, ترسكابيولر. اوكي بقول لك يا دكتور بس امشي ظهري بوجعني، نص ظهري بوجعني او كتوفي بوجعوني، ما في chest pain او توث اسناني بوجعوني او نيك بتوجعني. This could be other atypical site of ischemic heart disease. Should be aware about that when the patient came to you with toothache. Okay, if the toothache increased by exercise, okay, think about angina. Okay, angina chest pain is a clinical diagnosis من history نشخصها. Okay, physical examination most of the time normal. We do an ECG. Most of the time the ECG normal ECG will not rule out any form of ischemic heart disease. Even infarction can present with normal ECG initially. Okay, then we progress to investigation. مش مهم كثير بالنسبه لكم وانتم investigation. Okay, until we reach a proper diagnosis and to assess the severity and the extent of the atherosclerosis in the coronaries. Management of stable angina should have a goal in treating this patient with stable angina. One important goal objective is to improve the prognosis by reduction in the mortality. How we do that? By modification of the risk factor, quit smoking, proper control of diabetes, hypertension, hyperlipidemia. Patient should be on aspirin. Okay, all patients with any form of ischemic heart disease should be on antiplatelet. And the most widely used antiplatelet is aspirin. Okay, here we just a few words about aspirin that concern you as a dentist in the future. Aspirin, okay, as you know, is an antiplatelet. Antiplatelet, if you are going to do dental manipulation, this may increase the incidence of bleeding. Most of the time, patients with ischemic heart disease, with a stent or acute coronary syndrome, they will be on 2 antiplatelets for at least 1 year. Okay, and this again will increase the incidence of a bleeding after dental manipulation. So you need to be aware, and sometimes you need to stop this antiplatelet before, if you do dental manipulation, that might lead to bleeding. Okay, should be aware of that. Okay, and we know that half-life was about 5 to 7 days, so we need to stop it for this period. Okay, other important treatment line in patients with ischemic heart disease, any form of ischemic heart disease, stable angina, one of them is statins. Statin to decrease the low density lipoprotein to reach the goal with less than 55 milligram per deciliter. Okay, then we need to look for the risk factor, especially the modifiable risk factor. Give them aspirin, statin, beta blockers, ACE, then you may consider revascularization, okay, according to the extent and the site of stenosis, either BTCA or coronary artery bypass grafting. Okay, this is medical treatment, beta blocker, nitrate, sublingual, or oral nitrate. Okay. So again, correction of the risk factor, body weight, encourage exercise, treat other diseases that might increase oxygen supply, increase demand, or decrease oxygen supply. For example, if it's anemic, should correct the anemia to more than 10 grams per deciliter. If it's thyrotoxic, should correct the thyrotoxicosis, because thyrotoxicosis will lead to tachycardia, and this will increase oxygen demand to the myocardium. Treat arrhythmias, this again will increase oxygen demand. Okay, so we have different line of treatment: lifestyle modification, optimal therapy, and revascularization, BCI, or coronary artery bypass grafting. Any question till now? Prognosis of stable angina depend on the number of the visual disease, and the site of the visual disease. For example, single visual disease, a mortality rate per year with 2%. By now, this will increase up to 12% if the disease in the left main coronary artery. Okay. Any question before you go to the other type of coronary artery disease? في أي سؤال شباب؟ Let's see this example again. 50-year-old, risk factor عنده diabetes, is male, more than 45. Okay, is diabetic, complaining of chest pain of 2 hours duration, continuous chest pain for the last 2 hours. Okay, and this pain is retrosternal, heavy in nature, comes at rest, and not relieved by nitrate, sublingual, associated with sweating, nausea, vomiting, and this pain at the left shoulder. What is this diagnosis, or what's the differential diagnosis of this scenario? This typical scenario of myocardial infarction. Myocardial infarction usually comes at rest, sustained, persistent chest pain that lasts more than 30 minutes, and a chest pain that lasts more than 30 minutes comes sudden. Think about myocardial infarction. Okay, so now we'll talk about a few words about acute coronary syndrome. It's a spectrum of disease that range from myocardial infarction, ST segment elevation myocardial infarction, or non-ST segment elevation myocardial infarction that include unstable angina and non-ischemic myocardial infarction. Okay, it's characterized the same pathophysiology, where we have plaque rupture, atheroma in the coronary artery, plaque ruptured, as you see here. Okay, this plaque rupture or fissure or erosion expose the subendothelial layer to the circulating platelet. The platelet will come and sit here. It can lead to platelet adhesion. Try to heal this plaque rupture. by this mediated by von Willebrand, okay, and glycoprotein 1A, 2A. This will lead to platelet adhesion, then followed by platelet activation, and then platelet aggregation. This lead to formation of white thrombus or platelet-rich thrombus, and this will activate the intrinsic coagulation system that lead to fibrin deposition, and the thrombus will propagate over a few minutes till it occludes the coronary artery. When the coronary artery is occluded, the patient will have ST segment elevation myocardial infarction. If the artery is totally occluded, we have non-ST myocardial infarction or unstable angina. So acute myocardial infarction, in few words, it's the most common cause of death. It results from rupture of atherosclerotic plaque that lead to coronary thrombosis and coronary occlusion. Manifestations of myocardial infarction, about 85% to 90% will come with chest pain. And this chest pain usually comes at rest, early morning hours, dangerous hours, and usually persistent more than 30 minutes. Okay, usually retrosternal, radiator left shoulder, left arm, severe pain. This is the worst pain that a person can suffer in his life. Okay, could be compressive, could be burning, squeezing, heavy, في حركه بصدري, and this could be radiated left shoulder and more associated with nausea, vomiting, sweating, and not respond or not relieved by sublingual nitrate, عكس الانجينا. About 10-15% of patients with myocardial infarction may present with painless myocardial infarction, no pain, especially in diabetic patient, elderly patient. So how this patient present? He may present with hypotension, shock, or heart failure, or arrhythmia, or syncope. Okay, this could be a presentation of myocardial infarction without pain. But the commonest presentation of acute myocardial infarction اللي بالعربي الجلطة أو احتشاء القلب هو chest pain that comes sudden and persists more than 30 minutes, associated with more nausea, vomiting, and sweating. An examination, the patient looks anxious, stressed, sweaty, vital sign, but the pressure could be normal, high, low, depending on the situation of the patient. Pulse usually tachycardia. The pressure during the initial presentation normal, but after 40 hours may have low-grade fever. Sculptation normal. Sometimes we more S4, fourth heart sound, or third heart sound. Okay, after 48 hours we have pericarditis. Typical site of angina, but it is persistent more than 30 minutes. Angina, زي ما حكينا, the pain lasts about 5 to 10 minutes. When infarction, more than 30 minutes. Well, pain could be in other atypical sites. Could be epigastrium, severe epigastric pain. Could be shoulder pain or the scapular pain without chest pain. Okay, this is atypical site. Same site of angina. Diagnosis, history is very important. Then we do an ECG for this patient, and the ECG change may show ST segment elevation, like as you see here. Okay, ST segment elevation, diffuse on anterior leads, which indicate big infarction due to LAD occlusion. Then we do take a blood sample. Okay, look for cardiac markers. Okay, troponin, CPK, troponin start to be detected after 2 hours sensitivity. We have two types troponin, T and I. We have ordinary troponin. We have high sensitivity troponin. High sensitivity one start to be detected within 2 hours. Ordinary troponin 4 to 6 hours. Okay. بس مش كثير مهمة بالنسبة لكم هاي الشغلات هاي. Okay. Initial management should be started in the emergency room by giving mona, morphine, oxygen, nitrate, aspirin, heparin. Okay, طبعا كل واحد قبل ما نعطي أي دواء لازم نعرف الcontra indication. Okay, if there is contraindication, should not be given. Okay. Treatment. Okay, the emergency room, but put IV cannula, put him to the monitor, oxygen if his pulse oxygen is done in 90, give him aspirin, antiplatelets, clopidogrel. Okay, relieve his pain by morphine or dimorphine. Okay, then choose how you open the artery by BCI or thrombolytics. Okay, حتى the pain will persist as long as there is ischemia. Okay. And one important step in treating patients with myocardial infarction is the time to open the artery. The sooner the better. Time equal muscle. If you lose time, you will lose muscle. عشان هيك مثلا لازم ما نستنى ما نتاخر في عمل القسطره او ثرومبوليتيك حتى نفتح الشريان order not to preserve more myocardium. Prognosis of myocardial infarctions carry high mortality rate. About 20% of patients will die before reaching the hospital, okay, due to ventricular fibrillation. In hospital, mortality rate is still high, about 10%, okay, mainly due to cardiogenic shock, okay. So it is a bad disease. Within 1 year, the mortality rate is 1 year, 10%, so 40% will die within 1 year after myocardial infarction, okay. So what's the thing that's important for us as a dentist in the future for a patient with ischemic heart disease? This is a very important slide for you. So number one, should remember to avoid any tachycardia in patient with ischemic heart disease. إذا المريض عنده ischemic heart disease, ischemic heart disease, you should avoid any tachycardia. Especially, should have tried to avoid giving adrenaline, okay, because adrenaline sometimes with this will go to the circulation and lead to tachycardia. So you should be cautious when you're managing patient with ischemic heart disease as a dentist in the future. Try to avoid anything that increases tachycardia. Okay. Other drug should know the drugs that patient might be on. Patient with ischemic heart disease. Patient with ischemic heart disease usually on beta blockers. Okay. This is one cornerstone in treating patient with ischemic heart disease. Beta blockers. Beta blockers should not be stopped abruptly. لازم ما توقف المريض البيتا بلوكر المريض فجأة. Otherwise, he will have rebound tachycardia, rebound hypertension, and you may precipitate myocardial infarction. Should be aware of that. Number 3, patient with ischemic heart disease usually on antiplatelet. Should be on antiplatelet actually. Antiplatelet, another cornerstone in treating patient with any form of ischemic heart disease. And the commonest used antiplatelets is aspirin. This is the cheapest, safest antiplatelet. Okay. Other antiplatelets that might be on, like clopidogrel, ADP receptor, or ticagrelol, prasugrel. Okay. All these antiplatelets increase the risk of bleeding. Okay, so before you start dental manipulation, as tooth extraction, for example, okay, you should know what antiplatelet is taking and what's the half-life of this antiplatelet in order to avoid bleeding if you do dental manipulation as extraction. Number 4, patient with ischemic heart disease might be on anticoagulant, like warfarin, like DUAC, direct oral anticoagulant. Should differentiate between antiplatelet and anticoagulant. Okay, antiplatelet should be on patient with any form of ischemic heart should be an antiplatelet. Okay, anticoagulant like warfarin or DUAC like rivaroxaban or bixaban. Sometimes patient on need to be taking this anticoagulant in ischemic heart disease patient. Okay, again, this will increase the risk for bleeding. So should ask about what medication is taking. Okay, consider antiplatelet and anticoagulant that increase the incidence of bleeding and should stop it. Okay, before any dental manipulation that might lead to bleeding. Beta blockers should not be stopped abruptly. Otherwise, the patient will have rebound tachycardia and you may precipitate angina or myocardial infarction. I think this is enough for you. If you have any question, I'm ready to hear and answer. في أي سؤال شباب تسألون عن ischemic heart disease بالنسبة لكم as a dentist in the future؟ الله يعافيك. في أي سؤال؟ والله I don't know. متى امتحانكم المد؟ اكيد اذا الامتحان لسه ما يعني ذا فيوتشر حيكون داخل، لان اي ماده بتاخذوها قبل الامتحان حيكون داخل. طيب فحيكون داخل ان شاء الله. غيره اي سؤال ثاني؟ طيب شباب ماشي، اذا ما في اسئله يعطيكم العافيه. شكرا لكم.